About is the care of the imminently dying patient. And these are the things that we're going to cover. How do patients with advanced illness die? How do we prognosticate a short survival? And then how do we recognize and then manage the actively dying patient? So how do patients with life-limiting illnesses die? So conceptually, it's probably best to consider that they can die from an acute complication that brings on a rapid decline. So these are patients who are slowly declining with some sort of a chronic progressive illness and then have an acute complication and die almost in a sense unexpectedly. And then there are patients who have a progressive chronic illness that steadily declines to a phase of active dying in a way that surprises no one. And both of these trajectories occur in populations with chronic progressive illness, and so we have to be prepared to acknowledge, recognize, assess, and manage the dying process in both these populations. So an acute complication occurring in a patient who has a chronic progressive illness changes the prognosis from it could be weeks or months to it could be hours to days. And that obviously is an enormously impactful transition for families. And being able to recognize this and frame what is going on for a family obviously can have salutary effects in terms of their ability to manage it. But it all depends on whether or not the patient is being evaluated by a clinician in a way that recognizes and acknowledges that what had been a slow decline or an indolent course has now transitioned to something that's likely to lead to death in a short period of time. So these acute complications can be an expected part of the disease, and some of them are very challenging. For example, a patient who has an acute exacerbation of CHF or COPD is essentially always considered to be at death's door, but more likely than not, they survive. Right? That's one of the reasons that our ability as clinicians to prognosticate in those two populations is close to zero. And the reason is that every time they have an exacerbation that brings them back in the hospital, often in the intensive care unit, often intubated, those patients could die at any time. But more often than not, they do not. So it's a great challenge to know the transition to active dying from a slowly indolent course that occurs in the context of these two disorders. On the other hand, some events are very easy to prognosticate. If a person has end-stage renal disease and opts to stop dialysis or is no longer medically appropriate for dialysis, that patient will die. And it's predictable, no surprises. Other acute complications can also be either more likely or less likely to culminate in the death of the patient and allow one to transition the family from it could be weeks or months to it could be hours or days. And that would be the occurrence of sepsis, a bleeding complication, a patient with pulmonary embolism, a patient with hepatic encephalopathy, or a patient with stroke. So again, these things are commonplace, and the real reason that I'm bringing them up is just to acknowledge them as a clinical scenario that has high import. And if it's possible to identify this change in trajectory from a slow decline to a rapid decline, you can do a lot of good work just by communicating what's going on, supporting the family during that period of time. So when an acute complication occurs, what do? Obviously, review the plan of care for the patient and family, intervene, and communicate with the family to inform, provide support, make plans, and assess for family-oriented care. And that can be obviously the critical intervention when someone transitions from a steady decline to a rapid decline. But how else do patients with life-limiting illness die? Some patients do have a chronic progressive illness that slowly declines into a period of active dying. Now that can occur over weeks or longer, and that's obviously the great clinical challenge, because early in that process, it's difficult sometimes to know whether you're in it or not. But that can occur over weeks or longer. It's often not appreciated by your colleagues. And how do we know that? Because study after study after study that assesses the ability of physicians to prognosticate this subpopulation of patients show that physicians overestimate prognosis by weeks to months. So the usual clinician, your colleagues who are calling you for advice or curbsiding you, don't recognize when patients are entering the active dying phase, more often than not. The implications are often not understood by caregivers, and that's obvious by the conflicts, the tensions that very commonly are experienced, where caregivers may expect aggressive medical management to happen when we are thinking to ourselves that it would be appropriate medically to remove some of this aggressive treatment, since it isn't going to alter the prognosis, because we recognize that active dying has started. But the good news is, for those people who are interested in palliative care, anybody here interested in palliative care? Yeah. For those people interested in palliative care, the good news is that in contrast to the patient who's cooking along at home and suddenly develops sepsis and comes in the hospital and may be dead in 24 hours, and you're both trying to intervene medically while preparing the family for the worst. The difference with these patients is you have a lot of time, relatively speaking, to do the good work that you can do, to prepare family so that they can enter a period of bereavement with as much support and preparation as possible, right? So much of what you read about in palliative care relates to this, even though the more common way of dying is the other, right? So the challenge in the latter subpopulation is to predict when patients have a very short survival and may either be soon entering a phase of active dying or are now in a phase of active dying. So the clinical prediction of survival is a key goal of good palliative care, as you all know. Now, the clinical prediction of survival has been most studied in the cancer population, and it's very clear that even with metastatic solid tumors, which commonly have a course following chemotherapy, following the demonstration that chemotherapy is no longer helpful, commonly have a course of decline like this. It's very clear from studies that beyond 4 weeks, clinicians do terribly in prognosticating. Not just oncologists who do terribly even 2 days before, but we too. Everybody does terribly. Basically, in metastatic solid tumor, the ability to prognosticate more than a month out is almost zero, just in the same way that with congestive heart failure and COPD, the ability to prognosticate satisfactorily is almost zero 1 week out. You cannot do it. So it's sort of acknowledging your limitations, because it's important to frame the ability to make clinical decisions within knowing what's possible and what's not possible. However, within that period of time of 1 to 4 weeks, studies have basically shown that the clinical estimation, meaning to say a clinician goes to the bedside, gets a sense of the patient through an examination, that clinical estimation of survival is pretty accurate within 1 to 4 weeks for metastatic solid tumor. However, in other diseases, as I said, it's terrible. So what do we have to do? We have to gain we have to gain all the data that we can in order to try to improve what is essentially an inadequate clinical estimation of survival, right? So we have to acknowledge our limitations, and once we acknowledge that clinical estimation of survival is not that good, unless you're quite close to death, in the subpopulation with steady decline, once you acknowledge that, then you can see the value of potentially identifying other sources of data that might improve the clinical estimation of survival, might improve its sensitivity. Okay? So what are the other things that have been looked at? So the first thing that is clearly useful is performance status. And performance status has been used to enhance the clinical prediction of survival, and irrespective of the scales that have been used, the Karnofsky, the PPS, and the ECOG scale, all of them basically improve the clinical estimation of survival. So if you do an assessment of performance status based on one of these scales, you are more likely than not to improve your ability to estimate survival based on a clinical evaluation alone. As you know, however, these scales are clearly not able to give a level of sensitivity that's actionable. So you get a sense that things are closer to the end than you might have thought, or perhaps better than you might have thought. But there's so much variation in the population, it's difficult to act on this. And then obviously if someone has an acute problem, for example, a patient who develops sepsis or a pulmonary embolism, or develops a neurological disorder that keeps them in bed. The ability to estimate prognosis based on performance becomes more limited, right? So there are some data, though, that are helpful. For example, there was a study in Hospice of the Palliative Performance Scale that showed that if you had a Palliative Performance Scale of 30 to 40, 58% died within 1 month and 80% died within 3 months. In the same study, if a PPS of 50 to 70 showed that 33% died within 1 month and 69% died within 3 months. Interestingly, this study showed that the PPS worked a little better for non-cancer diagnoses and for patients in a nursing home rather than non-nursing home patients. So you can remember that because it's counterintuitive. You would think that the lower PPS would be more predictive for cancer than non-cancer, but in this rather large study, at least in the hospice environment, it was just the opposite. So it worked for both, and it worked better for the non-cancer diagnoses, and it worked better in a nursing home. So remember, 30, 40, 50, 60. This is a range in which the PPS is beginning to associate with a life expectancy within 3 months. And as you get down to the 30, 40 range, you're getting a relatively high likelihood of death within 1 month. This is the Palliative Performance Scale. This is the 30 to 40. So you'll see that patients who are in the 30 to 40 bed are mostly in bed. They're poorly able to function physically. They need help with self-care. They have reduced intake, and they may be fully conscious or they may be a little drowsy. So the PPS is a way of accumulating data on a number of different elements of performance. And if you look at the red lines here, you'll see that it focuses on self-care, intake, and conscious level. These have been looked at independently in other studies and might be used to improve prognostication. So let's look at some of these other studies. Again, we're talking about patients who are on a declining course from a chronic progressive incurable illness. And the goal is to have some sense that they may be moving from death is possible within weeks to months to death is going to happen very soon. Because if you can conceptualize that shift, that transition, you can begin to communicate with both the patient and family with different sets of priorities, and that could be helpful. So obviously one way of doing that is a clinical estimation. A second way of doing that is with performance status. A third way of doing that is looking at specific symptoms or signs that are predictive of a relatively short survival. And there are some data that help with this. For example, this study was done in the cancer population, and it found that breathlessness and what I've called an oral intake cluster, dry mouth, trouble swallowing, anorexia, and weight loss, an oral intake cluster, and confusion. Breathlessness, impairment in oral intake and weight, and confusion. Those three characteristics were highly predictive of a shorter survival in the cancer population. Okay, so remember those three now. Breathlessness, an oral intake cluster, and cognitive impairment. So remember those three. Now there have been tools that have been developed that are validated, and the tools will take performance status, clinical estimation of pain, and these other characteristics and attempt to develop a validated model. And as you all know and you've heard before, there are multiple tools that have been developed. The Palliative Prognostic Score uses the clinical prediction of survival. This is the one that we already said is not good beyond 4 weeks for cancer and not good at all for non-cancer. And then it adds to a performance status, which we already said, between 30 and 50 is pretty useful in telling you that a patient has a high likelihood of dying within 3 months. And then it includes anorexia, breathlessness, and then 2 laboratory values. Another tool that you've heard about is called the Palliative Prognostic Index. And this one uses oral intake, performance status, oral intake, edema, breathlessness, and cognitive impairment. So if you remember breathlessness, the oral intake cluster, and cognitive impairment, all or some of these appear on all of these scales. So, and the reason that I'm emphasizing that is because I'm not aware of many clinicians who actually use a validated tool in practice. So the question is, in the absence of a validated tool, which is great if you have the wherewithal to use it, but if you're like most clinicians, you don't use a validated tool. So what can you draw from the validated tools that provides actionable information? And I think the important points are, don't rely solely on clinical estimation. The patient looks sick, but realize that that's helpful, particularly if they have cancer. Rely to some extent on performance status, particularly if it gets to the point where the patient's in bed most of the time and needs help with self-care. And then also rely on a cluster that includes breathlessness, confusion, and an oral intake impairment. Dysphagia, weight loss, anorexia. That set of characteristics pushes people way down the trajectory toward much shorter survival. And this has been shown in a variety of different ways in a number of different studies. So it sort of gives it a sense that it's probably valid. If you look at it through the validation of the Palliative Performance Index or the Palliative Performance Score, or studies that have just looked at clinical estimation of survival, all of those studies tend to coalesce around that set of observations. Clinician estimation of survival plus performance status in the 30 to 50 range, plus breathlessness, confusion, and an oral intake cluster. Put that together in your file cabinets, label it as helpful in prognostication, and go forth in life.
You know, what's very interesting about those things is that they are also often observable by families and by patients. So it's not necessarily that we have to always go in and, you know, pontificate. You can help families because they see what you see. Many of those are very observable.
Yeah, I think that's a really good point, and we'll get back to that about how you communicate, Terry, and please weigh in at that time, because I think that's a very important point. Because when you have families that you know, based on your experience, it may be very helpful to transition them to the reality that their loved one is going to be gone very soon. And the question is, how do you show them that? Well, one way of showing them that is to say, you know, we know that when people mostly are in bed, and we know when people don't swallow so easily, or they become confused at night, we know that that's a sign that the end is near. And that kind of communication might be useful in some cases. Okay, so the question is, what are you going to assess as a clinician? Remember, repetition is the key to adult learning. What are you going to assess, right? Anyone here adults? Oh, okay, then I don't have to say it over and over again. Assess a performance status score and ask the question, is the patient spending more time in bed or a chair than before? Does the patient need help with ADLs? Is the patient spending more time drowsy or asleep, or possibly, as I'll talk about before, actually demonstrating an early sleep reversal, where they're sleeping during the day and they're up more at night? And then what do you assess in terms of symptoms? Now, obviously, from the clinical perspective, wanting to enhance comfort, you'll assess all symptoms. But that's often done in a busy clinical way of saying to the patient, what bothers you? And then you might ask a few probing questions. But if you are interested specifically in improving your ability to estimate prognosis, you want to inquire specifically about a few symptoms. Breathlessness, and that could be breathlessness with mild exertion. The oral intake cluster, dry mouth, dysphagia, anorexia, and weight loss. Confusion, and one study showed edema, which is not a symptom, but may be important. You can look at it. When looking at changes in cognitive status, as I said before, you can look at a whole range of emotional and cognitive capabilities. So you're asking about confusion, agitation, anxiety, or flatness in affect, or social interactions. All of these may reflect early cognitive change. And I think that is a common mistake that gets made, I think, by other clinicians, that they assume that, or their threshold for recognizing cognitive problems or mental problems or encephalopathy, the threshold is very high. A patient has to be confused in order for your colleagues to realize that they're looking at an encephalopathy. Whereas we know that an encephalopathy can have much subtler manifestations, a change in mood, or a flatness in mood, or inattention, poor concentration, sleep disturbance. Right? All of these things precede confusion. All of them are part of that cognitive impairment characteristic that predicts poor survival. So if you have a patient who has a disease that's characterized by a steady decline, like metastatic disease following chemotherapy or radiation, or a patient who has repeated episodes of more abrupt decline, you're always thinking in terms of the likelihood that this patient's prognosis is short enough so that part of the plan of care relates specifically to death preparation for the family, right? And you're always, that's part of the core precepts of palliative care. You're always thinking about, are we close enough to actually put on our agenda some specific work in order to assess the degree to which this family needs more preparation or support? So how do you do that? And the idea is to move in your minds from the fact that a patient may die sometime in weeks or months to a concept that they might be dying very soon. If some acute event has happened, like sepsis, all bets are off. But if the patient is in that period of slow decline, you can make the estimation that active dying may happen soon if you apply these sorts of assessments. A clinical estimation of survival complemented or supplemented by performance status, and then a specific look at symptoms like cognitive impairment, breathlessness, and that oral intake cluster. Okay? And then what do? We review the plan of care for the patient and family, intervene appropriately, and communicate. Now, what about the period of active dying? Until I got interested in palliative care, I had never heard the phrase active dying. And I was old. I know. In Canada, it's all the time. They use it in Canada all the time. We know that. But here in the US, since mostly we think death is an option, you don't really speak about active dying that much if you're a clinician. So, but the reality is, now that we're all doing this for a living, we recognize that there is this phase which is recognizable and actionable, and it can be called active dying. And the question is, how do you identify it? When is somebody in active dying? In contrast to saying that somebody is in palliative care, which I never want you to say, because palliative care is best care from the time of diagnosis on. You are never in palliative care. You are receiving palliative care throughout the course of an illness. In contrast to that, you can be in active dying. But you're never in death. You're just dead. These are nuances, but they may be important. Okay. I'm kidding. So what are the physiological changes associated with the hours before death, the hours or the day or two, this period of active dying? This can occur whether or not the decline is in the context of an acute deterioration, or if it's occurring slowly as part of a disease that's gradually progressing. And it has to be recognized to prepare the family and optimize the care plan. So what are the physiological changes that occur in these hours before death? Interestingly enough, when you go to the literature, there's very little evidence of this. Very few, very carefully done, rigorously performed observational studies. Most of what's in the literature are clinical observations from experienced clinicians. So I think that's just a framework. If anybody wanted to do research on active dying and apply very rigorous observational techniques to the active dying process, we probably could learn a lot, because we don't really know that much about the characteristics that are prevalent or less prevalent, and we don't know whether or not different diseases or different populations of patients vary in the way active dying occurs. But having said that, what are the sort of the broad characteristics that, that allow you to say potentially that this person is in a phase of active dying. So one element is declining responsiveness. This may look like coma, or it may occur with some vigilance, and the person could fluctuate from being vigilant or even hypervigilant to a period of a sleep-like state consistent with coma. The coma can be so-called light coma, meaning to say arousable to voice or tactile stimulation, or it could be deep coma, in which the patient doesn't even respond to deep pain. So there's a lot of variation when you say the person has declining responsiveness. The response to voice and contact tends to lessen over time until there's none, and occasionally active dying is associated with agitation even at the very end of life. We try to prevent that, obviously. Muscle tone often decreases and patients become flaccid during a period of active dying. But there may be myoclonic jerks, and sometimes families need education about what this is and what the meaning of this is. Any patient with encephalopathy from any cause will have a high likelihood of myoclonus. Incontinence may occur, and urinary output ultimately declines, so incontinence stops. So typically, in the period of active dying, incontinence is a sign of early active dying, and in late active dying, there's no urinary output at all, so the patients are not incontinent. Breathing often changes. Some patients who are actively dying have shallow and rapid respirations, so they're tachypnic. Some patients have slowed respirations, and some patients have Cheyne-Stokes respirations with apneic periods. And again, if anybody wanted to study this phenomenology in relation to the other characteristics of active dying, it would be very interesting. We don't have any idea. I don't have any idea, and I don't think it's in the literature how one predicts what the breathing pattern is, or whether the breathing pattern is adequately predictive of the timing to death so that it could be actionable. But everybody knows what Cheyne-Stokes respirations are. Cheyne-Stokes respiration is a pattern of respiration where the patient starts with normal breathing, then it gets shallower. Sometimes there's an apneic period, then it starts out shallow, gets more normal, and then declines again. And that periodicity can happen over minutes or sometimes over a longer period of time, typically over minutes. They vary back and forth between more normal respiration and shallow respiration or apnea for a period of minutes and then longer again. As you all know, some patients develop noisy respirations, and if those are occurring in a patient who is very poorly responsive, it's called death rattle, which is a term I've really never liked, because you keep on thinking a rattle is something you shake. So I don't get it. But in any case, some families are troubled by death rattle, and as you know, it's very common that palliative care specialists preempt this pharmacologically in order to try to reduce the risk that the families will be upset by it. In fact, there was just a paper published in the JPSM about advocating. This is a paper published by a very experienced palliative care team in Italy, which was a case report in which a patient with intractable death rattle, pharmacologically intractable death rattle, had the death rattle fixed by deep bronchial aspiration. And they were advocating for the palliative value of sometimes going in with an aspiration, a tube and an aspiration device in order to aspirate the secretions from the deep bronchi in order to reduce the distress that the family feels. And they presented a case report which I thought was pretty compelling, showing that in the context of palliative care, sometimes being quite aggressive to get to the endpoints that we value, you can even justify, as a clinician, something as aggressive as pulmonary aspiration to treat something that's not bothering the patient, but that's bothering the family. That was the point of the paper, which I thought was sort of interesting and had ethical issues as well. So cognition changes in this variable way. breathing changes in this variable way. And neurologically, patients are often flaccid with myoclonic jerks, and they may have urinary and fecal incontinence followed by no incontinence. Okay? What about vasomotor changes and other changes of the integument? So commonly the extremities become cool in the hours before death. Sometimes the skin becomes mottled or cyanotic, particularly in the extremities. And the skin of the face and body may change. This is again from the observations of experienced clinicians. Some patients have a mild cyanosis with a bluish discoloration of the face and body. Some patients are pale. Some patients appear to be flushing. There's sometimes a yellowish, waxy characteristic that's been described. And sometimes patients are sweating. So changes neurologically, changes in responsiveness, changes in breathing, and changes in vasomotor function and integument. If vital signs are taken during the phase of active dying, blood pressure is usually low, pulse is usually increased, temperature may be increased or decreased, and respirations may be increased or decreased, as I said before. So if the patient is identified as probably being in the phase of active dying, and that's now been recognized by the clinical team, what does it imply in terms of management? And one way of thinking about it is that you review the plan of care and see if the plan of care needs to be revised in order to address key concerns for the patient and for caregivers. So what are the key concerns during the phase of active dying? So remember, the phase of active dying is important because now we expect the patient to die very soon, within minutes to hours to a day or so. The patient is going to die very soon because they're actively dying. And so what are the key priorities during the phase of active dying? So one key set of priorities relates to decision making. If the patient has decisional capacity during the early phase of active dying, and parenthetically, we did a paper at Sloan Kettering many, many years ago in which we showed that a majority of patients had sufficient alertness to answer questions 2 days before death. So patients who are entering a phase of active dying, some of them are arousable. And again, that usually declines into a state of coma or agitation. But if they're arousable, they might be able to answer questions. So if a patient can answer questions, that may be time to talk about goals and preferences, anything that they would like to have done, anything they would like to have their families do. And we also would encourage, obviously, an assessment of the communication within the family, between the family and professional caregivers, and among professional caregivers. All of those are within the purview of palliative care. If the patient lacks capacity, this is the point at which, if you haven't done this already, you have to determine who is the decision maker. Is there a valid healthcare proxy or power of attorney for health decisions? If there isn't a valid power of attorney for health decisions, who will be identified as the surrogate? Are there oral or written advance directives concerning treatments at the very end of life? Remember, now in New York State, we actually have codified into law that a patient's prior expressed wishes must be followed if they are consistent with the context of the current clinical situation. They must be followed. And what is the status of communication? So recognizing the period of active dying, to me, is a good moment to take a step back and to saying, are we clear about how decisions are going to get made now? Sometimes another issue here is how are decisions going to be made at nights and weekends? If the patient is in a monitored setting, the question is who's going to make decisions at night or on the weekends? If the patient's at home, does this family know not to call 911? Or is the family going to call 911? So these are the kinds of things, once you recognize the patient's in active dying, the context of those decisions, who makes them, are they adequately informed, are they consistent with what the patient wanted, all of these things suddenly have great prominence. Another key concern for the patient is what the goals are, what treatments are available and medically appropriate. When patients enter the period of active dying in hospice, for example, it's very common for the hospice medical director not to hear about it until the IDT meeting, because the entire team has been preparing for this. So if the plan of care is well done, there's no need to call the physician if the nurse perceives that time is very short, unless there's a need for medical input in the plan of care. In the hospital, nurses on the units, if they see a patient suddenly go from more responsive to less responsive, or if they see a patient whose blood pressure drops 20 points, or they see a patient who develops Cheyne-Stokes respiration, the likelihood is a physician will be called. And the question is, if a physician is called, what's appropriate care? And it's really good if there's clarity about the care that a physician would order or not order before the call gets made. And that speaks in a hospital setting to the importance of handoffs, which I still think we could do better with in our department, because the handoffs on patients with advanced illness are very challenging, and especially in a hospital that encounters July once a year. It's very challenging to do handoffs well.
Handoffs also between nurses.
Yeah.
It's not just the physicians.
Well.
Oftentimes the handoff between nurses does not transmit essential information in terms of goals of care.
Yeah,
all that stuff.
that's undoubtedly true. And just another on that long list of things that I don't control.
No, but we can think about it, because we're palliative care, we can think about them.
So, and then of course this whole issue again of what are the expressed wishes of the family, of the patient, and how do the wishes and preferences of the family compare with those wishes. Another key concern is, where should the dying take place? So when you recognize that a patient may be entering a phase of active dying, it's not a bad time to ask the question, where should this death happen? And if there's already been a discussion about that, it's time to revisit the discussion. If there hasn't been a discussion about it, it's time to think about it. So can the patient die at home? As you know, somewhere between 50 and 70% of people, when surveyed, say that if they were able to get support for themselves and their family, they would like to die at home. Six or seven surveys have said the same thing. 3/4 of patients die in institutions. So is that a failing of the system? Is that a change in the perspective of a patient who perceives that there isn't enough support? Is that fear or desperation on the part of a family who hasn't been adequately supported? So the questions to ask: is there a need for more aggressive symptom control? Are there appropriate disease-modifying therapies that must be given in a hospital environment? What are the patient's expressed prior wishes? Can the family cope? And can the palliative care be delivered at home using continuous care? There's a 1,600 average daily census hospice in Florida, one of the best-known hospices in the country, that admit only 1% of their patients to die in their units. And instead, they use continuous care. MJHS, our affiliated hospice, uses a fair amount of continuous care. I think it's something like 10% of our total patient days, so it's relatively high for the industry, but they have like 16% or 18% of their days being continuous care days. But what they gain by that, in their perspective, it may not be the right perspective, it's the way they do things down there, that what they gain by that is keeping people out of institutions. Of course, we don't have data to know if that's good or bad, but it just is. It shows you this interesting variation even within the hospice industry. And it all relates again to whether or not you can deliver excellent care in the home. If you have a highly skilled RN, LPN, continuous care team, as they do down there, and MJHS has or may not have, depending on how staffing is going, then you can do this sort of thing. But always, I mean, again, from a physician perspective, I'm asking this question. You know, are there things that we need to do in a hospital that we can only do in a hospital, even if we have continuous care nurses there? Because continuous care nursing is nursing care. It can be very excellent, but it may not be the same level of interventions medically as you can get in a hospital, obviously. Can you treat the symptoms and disorders associated with patient and family distress? And the important point here, as you all know very well, is that even though the consciousness may be declining, the patient can still be in distress, at least until they're in deep coma. I'm a neurologist. I've always been comfortable that there's a level of coma at which or below which there is no distress. I know that some people who do this work for a living perceive that distress is still possible even if a patient's in deep coma. I have historically believed in the brain. Not everybody's brain, not all of yours, but a brain in general has to have enough function to perceive distress in order for there to be an experience of distress. But having said that, most people who are actively dying are not in deep coma. I shouldn't say that. I don't know that's true. But I will say it is likely that people who die during a phase of active dying start out that phase without being in deep coma. So there is a period during which they may be manifesting symptoms and signs of active dying, but they're not in deep coma. And obviously, if they're not responsive, they may be expressing distress through nonverbal communication, moaning, grimacing, rapid breathing of pulse restlessness. And that's why palliative care specialists are very willing, very interested in providing analgesic and sedative hypnotic drugs at the end of life, because the high priority placed on reducing distress and the difficulty in assessing whether or not distress is there. But you all realize, of course, that even that's controversial, although my sense is it's less now than in the past. But the controversy relates to whether or not we should give medications that reduce consciousness to people who are going through an experience that some would view as being a normal part of living and an experience that should be lived. And so, again, my own perspective is that we're in a process of continually assessing patients and families and making judgments about where they are at that moment. And if there is distress, I would prefer to recommend treatment for it. And if there is not distress, I'm comfortable not recommending treatment. And obviously, patients who have death rattle get aggressively treated with anticholinergic drugs and positioning in pulmonary toilet. One key element in the management of the active dying, of course, is terminal delirium, and you've probably all seen this schematic. This is from Frank Ferris's work, and he has called it 2 Roads to Death, which is a really disgusting title, but it's what Frank calls it. And so the difficult road is a road of agitated delirium until patients decline to coma and then die. And what he calls the usual road is the road of hypoactive, either hypoactive delirium or a state of gradually declining consciousness through obtundation, stupor, and coma. So one way of thinking about this is that encephalopathy, diffuse brain pathology that culminates, or I shouldn't say culminates, diffuse brain pathology that ends when the patient dies can have any number of different manifestations, as I said before, and basically anything that the brain does can be perturbed during that period. So we're talking about cognition, perception, emotional processing, social processing. Everything the brain does can be perturbed. But if you wanted to make it real simple in terms of clinically actionable kinds of characteristics, some people would say that one approach is to look at declining brain function in terms of a decline through obtundation, stupor, coma, and death, and one through a pathway that takes the form of delirium, which is associated with fluctuating level of consciousness, impaired cognition, and may be associated with agitation. And the unfortunate thing, of course, is that patients who have hypoactive delirium are not often treated for delirium. And there's at least one famous study that suggested that patients who have hypoactive delirium and then awaken some of those patients will report that the experience of being delirious was terrifying. So so if a patient who's thrashing around and screaming will get my attention, a patient who's resting quietly will get my gratitude. And if you're just resting quietly, you're not likely to get a neuroleptic or a sedative hypnotic, but if you're thrashing around, you're likely to get both. And the question is, are we assessing the patient who's quiet as moving through a period of obtundation, stupor, and coma to death, Or are we assessing that patient as having a hypoactive delirium that might warrant treatment because of our concern about the experiential characteristics of a hypoactive delirium? Is that all clear? What's that? How do you tell the difference? Yeah, sometimes you can't. I don't know. I mean, clearly, a hypoactive delirium is because it has a fluctuating level of consciousness. If the patient's being assessed periodically, you're going to be able to see something that makes you say, something's getting in here, right? But, you know, honestly, why do you think that places like our unit are so prone to treat the dying patient with sedative hypnotic drugs? When I arrived here 15, this is a famous story that Terry has heard at least 27 times, so just cover your ears, Terry, because there are new people here, right? So when I arrived here 15 years ago, and Dr. Lesage remembers this, I brought together all the nurses on the unit, and one of the nurses stood up and suggested that I was going to last about 3 weeks and then I'd be out of here. And that same nurse also suggested that they didn't really need any medical sophistication because they knew what they were doing. And basically they needed morphine and Ativan. And if they had morphine and Ativan, they could basically manage everybody on the unit with any problem at any time. And who was I to disagree? So, no, I did disagree gently. And I hope today that we're a little bit more astute, that we give morphine for pain, and we give a sedative hypnotic or a neuroleptic to reduce agitation or impaired consciousness when it's appropriate. Not in everybody. But there's a high likelihood that it's going to be used, right? So terminal delirium has early signs, and this is really apropos of what the question was. If a patient does have some restlessness, expresses anxiety, has sleep reversal or insomnia, drowsiness during the day, tremulousness, poor concentration and attention, illusions, hallucinations. Remember, delirium, one way of thinking about delirium is that it's sort of a common final pathway of a set of processes that can occur in isolation or in combination. So some people will end up in delirium after having an experience of poor attention and poor concentration, memory lapses. Some patients will get there after experiencing organic mood disorder, anxiety, or depressed mood, or mood lability. Some people will get there after experiencing perceptual disturbances. They'll have illusions or even hallucinations, right? And some people will get there with some combination of those disturbances and end up with a frank delirium. So because any of those things happen, if you assess them, including this fluctuating level of consciousness through sleep disturbance and sleep reversal, if you can assess them, you can say, you know, I think this encephalopathy is an early delirium. Why don't we treat this and see if the patient's more comfortable? And by the way, you're probably all aware of very limited data, but some data to suggest that if the process is delirium, the more specific treatment is a neuroleptic. So a sedative hypnotic drug will cause a reduced consciousness and reduce agitation and anxiety, but a neuroleptic will reduce impaired thinking. And so in one randomized controlled trial that compared 2 different neuroleptics to a benzodiazepine, both neuroleptics were better in reducing the symptoms of the delirium, although the benzodiazepine reduced the agitation, but the neuroleptics were more specific. Also, other studies have shown that if you give a neuroleptic, they always work transiently unless you reduce or relieve the underlying causes of the delirium. So it's not uncommon, for example, to have a patient come into the unit or to be in home care and that patient's given haloperidol and they feel better, but a week later they don't feel better, and at that point you begin to think, should I add a benzodiazepine, help this patient sleep at night or help this patient with anxiety? Yeah.
Are you aware of any evidence for the use of Aricept in delirium?
Yeah, there's in Alzheimer's disease, there's some evidence that delirium can improve with Aricept, but it's very limited.
Is that the only cause that it has been in relation to dementia?
Yeah, to my knowledge, dementia with delirium. I looked at those data about 3-4 months ago for something else, So unless there's something more recent, I didn't find it.
We have received information about a patient that may be getting transferred, and it was being used in a patient that was post-op of a UKA that had developed dementia or
Delirium.
a history of mild dementia. So we weren't sure if that was a treatment that would work and that would help, or if that was something that was available.
I think they referred.
I looked, and there wasn't that evidence based on what I thought.
I think they refer to UDAP agent for patients with delirium superimposed by dementia.
Yeah, that's to my knowledge. When I looked at this some months back, I was looking at whether or not the acetylcholine drugs, cholinesterase inhibitors like Aricept, were useful for delirium. What I found was some data to suggest that delirium superimposed on dementia was reversed with those drugs. But I didn't find any evidence at that time that a delirium associated with infection, for example, was improved by that. So I think that
It's only dementia patient. Actually, one of the cholinesterase inhibitor comes in a patch, and it is approved for delirium associated.
Oh, I didn't know that. Is that
dementia
right?
Patients, one of them.
That's interesting. Okay. Well, so how do you manage delirium? I just last 2 Wednesdays ago, I was having a medical meeting with the hospice medical directors, and I decided to take a poll about the use of hypodermoclysis. And what I did was I gave a case history, which was a real life patient I made up, and then I asked them how they would manage this patient. And one of them said that they would consider hydration as an intervention to see if it reversed a delirium. And all the other physicians and NPs in the room said that they would not. And then we talked about the fact that this is controversial in the US. It's been controversial for about 10 years. And there are programs and researchers who think that early delirium if early delirium is associated with any signs of dehydration, which is common, a reasonable intervention is to try to rehydrate, and if a patient doesn't have IV access, to do that through hypodermoclysis, and to do it as a trial, because their anecdotal experience, case series experience, suggesting that if you rehydrate patients, some patients will have clearing of cognition, and that can be a valuable goal, even in patients who are very sick. So I think my preference is that we don't lock ourselves in a box here. You know, it's perfectly okay for an experienced clinician to be of a mind that death is imminent, and let's do death preparation, let's manage symptoms, and not worry about any disease-modifying therapy. On the other hand, if this patient or this family was interacting, interested in more time, had things that were left undone, and you could possibly prolong time with intact cognition by giving fluids, then you should give fluids. And hypodermoclysis is underused. It's very easy to do. It can be done in the home. It can be done by bolus or by continuous infusion. It can be done with or without hyaluronidase. If you add 1,000 units of hyaluronidase, you can give patients liters. You can give patients a liter an hour subcutaneously. Has anybody seen how hyaluronidase works? It's very dramatic. Hyaluronidase, you know, lyses, it's an enzyme that lyses one of the interlacking connective tissues under the skin, and basically produces a situation in which the fluid rolls under the skin. And if I actually once observed a demonstration in which a young, healthy man who had very little room under his skin got 200 cc's of saline pushed through a butterfly, and his skin tinted and it was uncomfortable. And then he had 200 cc's of saline with 50 units of hyaluronidase pushed in on the other arm. And there was no tinting of the skin. As it was pushed in, the fluid just went right up his arm. It was very dramatic. It happens instantaneously, it's very low risk, and the only issue is cost. So, hydration, you'd want to consider environmental interventions like positioning near a window, removing objects from the room, having a person at the bedside. This is all to reduce delirium, the symptoms of delirium, neuroleptic treatment, sedative hypnotics for agitation, and obviously communication. Another key concern in the actively dying patient is when is palliative sedation appropriate? And you all should know now that it's a medical treatment by which a patient who is believed to be near the end of life is given a drug with the goal of producing sedation sufficient to relieve suffering. That's the definition of palliative sedation. It's considered for distress at the end of life. When routine interventions have not worked, that means you have to know what routine interventions are and have done them. And it's ethical if the intent is to relieve suffering and to fully distinguish it from hastened death, which is euthanasia or assisted suicide. It has to be clearly distinguished through open discussion, consent, and documentation. Right? So when we do it downstairs, we have a policy that's been in my inbox for a while. We're going to redo it, finish it, and then roll it out. Probably not until our current batch of fellows is gone, but we'll get there. But the bottom line is it's about communication, consent, and documentation of a policy, of a medical intervention that is clearly ethical to do. At least we believe so in the United States and most of the developed world. We believe so if the intent is to relieve suffering. Communication, as I mentioned repeatedly, is really key in patients who are imminently dying. And as you all know, that we emphasize the importance of having communication informed by the medical facts of the case, respectful of culture and values, sensitive to the potential for distress in the people to whom you are communicating, and also cognizant of communication barriers, which can be cultural, psychosocial, or issues related to listening or language. Strategies to encourage communication include awareness about nonverbal communication, multiple short conversations instead of one long meeting. Remember, nobody remembers anything from one long meeting. And when you're trying to give them information, trying to give a family information about the likelihood that their loved one is dying and what that's going to look like, the chances are they're walking out of the room with very little of what you've told them. Honest and open communication and answering questions. And I'm just going to stop there. So any questions or comments about care of the imminently